Do you really need a brace after proximal hamstring avulsion repair? Because this paper suggests maybe not. Welcome to Sunday Paper Roundup, where I read the paper so you don't have to. I'm stepping slightly outside of my immediate sphere this week, not wildly. This is still very much sports injury, rehabilitation and low limb surgery, but I know some of the authors personally, Shabazz Malik, a recent ISCOS traveling fellow, and Randeep Aujla, good guys doing great work up north. And the senior author is Pete D'Alessandro, who I only know through social media, but he's got a great reputation and a highly sought after fellowship in Western Australia has become one of the hottest tickets in town due to the excellent training and exposure given. And based on how many international presentations and talks he does, he must have a lifetime name, image and likeness deal with Smith & Nephew that would make the likes of Ronaldo, Messi or David Beckham jealous. So anyway, I thought I'd critically analyse a paper that sits just beyond my usual lane. This is not an area of my main practice interest, but it's still highly relevant to me because as a sports knee surgeon, accelerated rehab, avoiding unnecessary restrictions and limiting the complications of bracing, stiffness and a delayed recovery all matter a great deal. And although proximal hamstring avulsion repair is not my area of main focus, I do see a lot of distal hamstring injuries, and this is just the top end of the same muscle tendon unit. This is still very much adjacent territory. So let's dive in. This is the FARLAP study, a randomized controlled trial published in the American Journal of Sports Medicine, which immediately makes it worth taking seriously. They looked at patients undergoing proximal hamstring repair for acute avulsion injuries involving at least two tendons and randomized them into two rehab pathways. The conservative group had 6 weeks of knee bracing and restricted weight bearing, and the accelerated group had no brace and full weight bearing as tolerated, really going for it. Now, this is a highly practical question because post-op protocols in this area are all over the place, and the paper makes exactly that point. There is major variation in bracing, weight bearing progression, and time to full weight bearing after these repairs. So what did they find? Well, at 2 years, there were no major differences between the groups in most patient-reported outcomes, strength recovery, or hot performance. The accelerated group did have a better SF12 physical score at 3 months, a lower hamstring pain severity at 3 months and 12 months. But in the bigger picture, the groups were largely comparable. Peak knee flexor torque improved over time, peak knee extensor torque improved over time, single leg hop distance improved over time, and limb symmetry improved over time. But there were no significant group differences for those objective outcomes. So the main message is straightforward. Accelerated rehab did not appear to be worse, and that matters because if you can safely reduce bracing, restriction, and unnecessary early disability, that matters to patients, to therapists, and to surgeons. Now, what does the paper get right? Well, first, it's a prospective randomized trial that immediately puts it above the usual retrospective protocol literature that dominates this space. Second, it looks at outcomes that actually matter. PROMs, strength, function, and re-rupture. Third, the question is highly practical. This is not theoretical biomechanics. This is, do I brace? Do I restrict weight bearing, or do I let people get moving sooner? That is a real-world rehab question. And now the critical analysis. This is the bit I can do. The first issue is sample size. This was 57 patients total, 30 conservative, 27 accelerated. That is respectable for this injury, but it's still small. And the authors are appropriately honest. The study was not powered to detect differences in re-injury risk. That is important because re-rupture is the thing that most people will care about most. There were 4 re-ruptures over 24 months, 2 in the conservative group, 2 in the accelerated group, for an overall re-rupture rate of 7%. But with numbers that small, you cannot confidently conclude that re-injury risk is identical. Second, although the rehab pathways were defined, there was still therapist discretion in how rehabilitation progressed. That reflects real clinical practice, but it also introduces noise. Third, this is a specific cohort, acute injuries aged 18 to 65, at least 2 tendon avulsions and surgery within 6 weeks. So do not overgeneralize this to chronic tears, partial tears. London, fucking hell. So do not overgeneralize this to chronic tears, partial tears, non-operative cases or revision situations. Fourth, full weight bearing is tolerated without bracing does not mean do whatever you like. It still means structured rehab, controlled loading and sensible progression, and that distinction matters. And finally, this paper is about rehabilitation after repair. It's not a paper about who should or should not have surgery in the first place, so do not let people flatten that decision. My take home, this paper makes me more comfortable with the idea that after acute proximal hamstring repair, we may not need to default to rigid bracing and heavily restricted weight bearing for everybody. Not because this paper proves accelerated is superior, it doesn't, but because it suggests accelerated is probably not inferior in the outcomes that were measured, while possibly making the early recovery experience a little better. So what's my verdict? Should we ignore it? Should we be aware of it? Should we go right ahead and change your practice? My verdict, go ahead and change your practice, but not by becoming reckless, not by pretending this answers every question, but if your current default is rigid bracing and heavily restricted weight bearing for every acute proximal hamstring repair, this paper gives you reasonable permission to rethink that, especially because the authors themselves state that after completing this study, they adopted weight bearing as tolerated without bracing as their standard of care. Let me know if you want me to reach out to other areas, not just knees, for future Sunday paper roundups. Either way, I'll see you next Sunday. I'll keep breaking down the evidence as it lands.